Yeah.
Pramosa, are you there?
I think he's logging.
Yeah, I'm here.
All right. Okay. Okay. Today we are going to have the second session of the Viva-based discussion per your request, the final year request. So today we are going to start with this photo. Guys, who is doing the first case?
Any volunteer?
Me, sir. It's me, sir.
Senali. Okay.
Yes.
Right. Okay.
Senali.
Yes, sir.
Yeah. Can you actually appreciate what you see there in the photo?
I can see a gangrenous wound over left foot in second toe, sir.
Okay. Can you describe more
There
about it?
are a sharp line of, it is blackish in color,
Mm-hmm.
and there's no oozing. It is dry.
Mm-hmm.
Also, there's a sharp line of demarcation, shriveled,
Okay.
and not much mummification could be seen.
Mm-hmm. So what is your final?
No proximal extension.
No
It
approximate
is a dry
extent.
gangrene, sir.
It's a dry gangrene. Okay. So what else do you have to appreciate in this food when you actually want to see in a real person? What else are you going to
There's
check? And yeah.
nails, pulses
Okay.
between toes.
All right. So if you want to take a short, very brief history, say in a few, you'll ask few questions. What questions would you ask the patient?
Onset of this wound. Also, the comorbid conditions such as diabetes.
Mm-hmm.
Also, any other symptoms such as difficulty in speech, blood visions, the comorbidities such as vascular disease.
There's a background noise coming from somebody. Can you just mute the other? No.
Guys, please, others, please mute your microphones.
Okay. Sonali, why did you ask about the TI and stroke in this patient?
There can be a peripheral vascular disease as a
Okay.
combination.
So what's the relevance with the foot?
Also, risk factors such as smoking.
Mm-hmm. And don't you want to ask about the age?
Yes, age, gender, also hypertension, dyslipidemia, renal insufficiencies.
Is there anything else you have to find out in the patients as to find out what's going on with these patients?
Also, sir, sorry, sir.
Is there anything else you need to ask?
Aggravating factors. Aggravating factors, sir.
What do you mean by aggravating factors?
Whether the pain is related to his position, working.
Can you be more precise can you be a little more precise of what you're asking?
Onset and progression of pain, sir.
If you're thinking of a particular condition, what's the kind of pain you'll be asking? Can you describe the pain of this kind of patients? Is there any relevance with this?
Cramping type pain, sir? Cramping type pain?
Cramping type pain, where? Where?
That is in calves.
Okay. Why? Why did you ask cramping type pain?
There can be obstructions due to peripheral vascular diseases. According to site of obstructions.
So why do they get cramping type? What is cramping type pain? Can you describe the pain the patient will experience?
It is an unbearable pain, sir.
No.
Breast
What?
pain.
Sorry?
Breast pain, sir.
So you're now telling so many things. Now you're saying the cramping pain, now it's getting the breast pain. So what is breast pain and what is cramping pain you were talking previously?
Yes, cramping pain is, sir, it is exacerbated with exercise and relieved by standing.
Not really. It's no pain at rest. And it's brought about by exercise and then should be relieved by rest. So that is intermittent claudication. Is that what you're doing?
No, no.
Okay. What's the other condition you were telling before? So you're telling about the rest pain?
Sorry,
So
sir.
what you're talking about rest pain. What is rest
Yes,
pain? So if the patient has got rest pain, how would the patient describe to you? Okay. What do you understand by
it is a
rest
severe
pain?
pain, sir. It is a severe pain. Pain is aggravated even with blood clots. So it is increased at night.
Okay. Ideally, it has to be the forefoot region where you get the pain, and then it's worse in the night. It's not relieved by regular painkillers. So
Yes.
that's kind of, and you should appreciate the ischemic symptoms other than that. All right. So what are the things you're going to check in these patients other than the foot? You're talking about the pulse. So what pulse
Yes.
actually would you check here? The leg.
Ankle pulses.
What ankle pulse?
Dorsalis pedis.
Uh-huh.
And anterior tibia.
Okay. Where would you feel that dorsalis pedis pulse?
Since dorsum area of the foot.
Yes. Where?
Yeah, like near the second toe, below the second toe.
It's just like, yes, it should be the base of the metatarsus
Yes.
and just lateral to the extensor hallucis longus tendon. So that's where. All right. So what's the posterior tibial pulse? Where would you check it?
Posterior tibial pulse is in medial malleolus.
Sorry. Sorry.
Medial malleolus of the
In
foot.
front or behind?
It was behind, sir. Behind.
Are you sure?
Yes.
Okay. Right. And what else are you going to check in the pulse? Where else are you going to check?
A popliteal pulse.
Uh-huh.
Also femoral pulse.
Mm-hmm. Anything else? Anything else? That's all. How about the other leg?
Hello, sir.
Yeah. How about the other leg?
I have to check other leg too, sir. I have
Why?
to other leg too. Because
Why do you
there can
want?
be
There can be. Yeah. Why are you going to check the other side? There can be. Can you complete your sentence? Hello? Sonali?
Hello, sir.
I can't hear you.
Hello.
Yeah.
Hello, sir.
Did you hear me?
Yes, sir. I can hear you.
Yeah, yeah. So why are you going to check the other side?
I have to compare with other leg as well, sir.
Why? Why do you want to check the other side? Why do you want to compare it?
Sorry, sir.
Why do you want to compare it?
Because there can be contralateral in ischemia as well.
Contractile ischemia as well. Okay. Anything else? If there's pulse on the other side, is it compared? Say there's no pulse on this side. Is it likely or unlikely?
It is likely, sir.
No, it's. I mean, if it is peripheral vascular disease, it's unlikely to get pulse on the other side. But there can be sometimes variations. Can you think of any other condition which you can actually have a good pulse on the other side foot, whereas you can't have any pulse on this side?
It's unilateral vessel obstruction.
If it is peripheral vascular disease, usually it's bilateral, but it may be severely affected on one side. That's true, but usually it's bilateral. But there can be other variations. The one variation is there any other condition which you can actually have this situation? You can have good peripheral pulse on the other side, but there is no pulse on this side. Can you think of any other condition?
Baker's cyst.
Now you can't have Baker's cyst and giving rise to dry gangrene like this, so it has to be ischemia of some sort of. Have you heard something called acute and chronic ischemia?
Sorry, sir, I couldn't hear.
Have you heard something called acute and chronic limb ischemia?
Yes, sir. Yes.
Okay. Right. And there's other condition called blue toe syndrome. And you can have actually good peripheral pulse, but still you have gangrene in the foot. So that's due to emboli. So this can happen due to two reasons. It can be due to atherosclerotic occlusive artery disease, and microvascular getting compromised, and also due to atherosclerotic plaques which have emboli causing small vessel occlusion. So what in this situation, sometimes you can get good peripheral pulse, but still they can have dry gangrene like this.
Okay.
Is that clear? Okay.
Yes,
Right.
sir.
And don't you want to look at the other side also, whatever the plant aspect of this patient's foot?
I have to check for wounds in plant aspect, sir. If the patient is having diabetes.
Anything else you want to check other than wound?
Yes.
Nail, of course, you can see here. Say this is a diabetic patient.
Diabetic ulcers, sir.
You are talking about wounds. Other than ulcer or wound, is there anything else you can actually appreciate? You should appreciate diabetic patients.
Loss of sensations. I have to check for loss of sensations.
What else? Say there's actually a reduced sensations in diabetic patients. Huh?
Joint deformities.
Like what? Yes. Yes. Other than Charcot foot, other joint deformities they get.
Bunion.
Bunion. Okay. What is bunion?
It's bulging of weight or outside bulging.
Sorry, bulging of.
Outward bulging of metatarsal joint.
No, that is hallux valgus deformity. Bunion is not that.
It is base of dystrophy.
Yeah, basal big toe has just enlarged and causing bursa kind of thing. Now, what else do you have? Say we have hallux valgus deformity, and what else can you have? Well, what happened to the rest of the toes? If you have hallux valgus deformity, this patient also has got some sort of hallux valgus. I don't know, which mildly weak at all. But what happened to the rest of the toes?
There are some wounds in little foot toe as well, sir.
Mhm. The toes, say you get your hallux valgus. You know, valgus means the lateral rotation, lateral deviation of the big toe. And with that, what happened to the rest of the toes? You get overcrowding. You see, the toes become overlapping sometimes. And what are the other deformities you would get in a patient with diabetes? Toes? Hmm? Hemato? You had hemato. Okay, and what happened to the arches?
Arches are
What are the arches to the foot you get in the foot? Yeah.
arches are really also
How many arches do you have?
2 arches. Sir.
Oh, okay. What are they? Hmm? There's a transverse arch of the foot, and there's a medial and lateral longitudinal arches. So, to 3. So these arches might flatten, and it was a flat foot deformity, diabetes. Charcot, of course, you get in very rare patients in diabetes. It's not that common. Okay. So look, there are a lot to talk. Actually, I don't know whether we have time.
Yeah, yes, sir. I think we better move on to the next one.
Yeah.
Okay.
Okay.
Yeah, Pinto.
Oh, sir.
Yeah. Okay. Can you just move the previous one? A couple of just few questions. Can someone answer? So if you do well in the short case, I think Aruna sir discussed. So basically, up to the diagnosis and around it. But then if you have answered well, probably in a case like this, we might ask you questions about the management. Aruna, you didn't ask anything about management, no?
No, I didn't ask about management.
Probably you might ask a couple of questions about the management and bit of if you do really well, and we might ask a little bit about the pathology as well. Can someone I'll ask maybe few questions, 2-3 minutes. Can someone answer? Can someone join up? Okay.
Yeah.
Has anyone who's there? Is anyone there?
Can someone answer the management part actually?
So I'm
Okay. What is your name?
so I'm Senali. So the previous one I'm joining my
Okay. Can you ask someone else because you already had enough?
Yeah.
Quickly. Maybe someone from the final year. ඉන්නවද කවුරු නැද්ද? නෑ.
HM Jayasinghe?
ඉන්නවද? නෑ ඕනේ කවන්නේ. Then we'll move to the next one. Pinto, that's okay. You move to the next one.
Okay, sir.
Okay. Who's going to be volunteer here again?
Sir. Hello, sir.
Nwangi. Okay.
Yes.
Okay, Nwangi. Can you describe what you see in the pictures given here?
In the first picture, sir, there is a below knee amputated limb on the left side. Left side below knee amputated limb.
Left or right?
Sorry, right side. Right side.
Okay.
And the next picture.
It's more closer view of that. Okay.
Mhm.
To facilitate you, and it's the same patient. What about the third picture? The same patient.
Same page. That's
Yeah.
no complications or any ulceration.
Sure.
Mm.
Are you sure? No problem with the other side.
There is fixed flexions. Fixed.
Mm-hmm.
Mm.
Section, of course, can't actually appreciate it because you have to move and see.
Mm.
But there's some kind of something there.
I don't know. I'm not sure, sir.
We'll come back to that later. So concentrate on the right side. So what do you think with the appearance there? Are you happy with this?
No, sir. There is a blackish discoloration of the toes with pale nails.
No. I'm talking about the right side.
The leg.
Yeah. Are you happy with this stump there? So we call it stump, isn't it? What kind of a stump is it?
It's a
Cylinder?
cylindrical in shape.
Now, can you describe what kind of a stump is it?
Below stump.
Okay, below stump. Right. So are you happy with this stump seen there or not?
Yes, I'm happy. There is adequate tissue distance from the knee joint.
So, all right.
And
okay. And what happened to the scar there? Is it? It looks okay. No infection, is it? Or is it an infection?
some necrosis is like blackish discoloration is there. So.
All right. Okay. Forget about discoloration. I mean, it looks okay to me. I mean, there's no much discoloration seen. Anything else you're going to check here? So if you get this patient now, what are the other things you're going to check?
Whether there are any muscle wastings in the quadriceps.
Where? Quadriceps, okay.
Quadriceps.
All right.
And any contracture formation.
Okay.
And then the mobility of the knee joints, whether the power of the hip flexors and extensors, and on the if the patient has a history of peripheral vascular disease, I would like to look for the pulses of the contralateral limb as well. And
so what about the pulse here on the same side?
Yeah, I would look for the popliteal pulses as well, sir. And
only popliteal
pulse. And the carotid pulse.
Popliteal pulse, even though you are trying to feel it, you will not feel it at all. Normally, you don't get popliteal pulse after belonging. Okay, there's no point of checking that. Right. Now, is this stump shape okay? And is the shape all right?
Yes, it's cylindrical in shape.
Okay. Is that the accepted thing for something?
Initially, it will be cylindrical in shape. It is a very recent amputation, but with time, it needs to be conical in shape to have a prosthesis for this patient.
All right.
So,
okay. So it has to be molded.
Molded.
Okay. Yeah. Okay. It's not yet done. Fine. Okay. Say there's a kind of a contracture. So what kind of what degree of contraction would you accept for you to have lymphedema prosthesis?
Mm,
Any idea?
there should be no contractures, sir.
Yeah, that's the ideal thing, but there can be sometimes minor degree contraction.
Mm,
And what degree of contraction, if there's some kind of contraction, so you would consider it as absolute contraction for prosthesis.
mm, I'm not sure, sir.
All right. So it's 130 degree, and if there's more than that, so obviously you can't have any processes. What about the, you talk about the quadriceps wasting. Where would you check that? And what would you do to prevent that happening?
I will check quadriceps in the anterior thigh. And to prevent that, we should start physiotherapy from the day one following the surgery.
Okay, what kind of exercise are you going to recommend to this patient? Because patient is having some pain and after surgery. So day one, what kind of
stretching exercises, sir?
Stretching. Do you think the patient is able to do that immediately after operation or day one? What are types of exercises do you know? Muscles have two types of exercises or actions. Any idea? Physiology? Static and dynamic. So what is static and what is dynamic?
Static means that the muscle is not moved, but the weight is given to the muscle. And dynamic means the muscle is contracting.
Oh, it's the length of the muscle varies.
Okay. It varies.
So initially what you recommend is the static exercises. And later on you do the dynamic things. Okay. Right. But earlier the better you give the patient's mobility and start mobilizing. So that's going to prevent the quadriceps wasting. Right. So what about the other side? You said you talking about something abnormal here in the foot?
Yes.
Regular contraction. So what sort of what concept on the lateral toes? Can you see on the first picture something abnormal?
Yes.
What
there is charcoal foods.
No, it's not charcoal food. What has happened to the metatarsophalangeal joints? What has happened there?
They have been hyperextended.
That's right. And what about the rest of the toes? The joints? Yeah.
Flexor.
So what kind of a deformity is it?
Claw.
Claw fingers. It's a claw toe deformity. Okay. And the big toe also is just plantar mostly. So what happened to if you have, if say you have got a claw toe deformity, what happened to the toes and say some patients develop callosities? Where would they develop callosities?
On the pads of the sole.
It's not the pad, it's the tip of the toes. Because the tips are going to face the ground there. They are going to rub and then causes all the friction injuries. So that's the problem. The pads are not vulnerable to injury, whereas the tips are not. So okay. So say that this patient is post-op day 7 after operation. Nice nail. I would say it's 14 days after operation. The stitches have taken off. So you're going to send this patient home. What would you do? What would you recommend?
I would advise the patient the importance of the proper follow-up and the optimizing of the
What's the kind of follow-up do you need? What's the kind of follow-up?
For his comorbidity, other comorbidities, like if the patient is having ischemic heart disease, diabetes mellitus, and then
okay, I accept that. Anything else?
and also I would advise regarding the complication of this amputation, like phantom limb syndrome, which should have been ideally advised in the pre-operative period as well, and advise the patient to have their home environment, how to keep their bed near a wall, because there is a risk of falling in phantom limb syndrome. So to keep the bed near a wall and sleep with the affected limb on the side of the wall, so that the next day morning, when he get up, there is a reduced risk of falling, since the get up with the normal limb, keeping the normal limb to the floor. And then further advise the patient to rub the rest of the limb, and
rub with what?
With hands.
For what?
To inhibit the impulses that comes from the, now in phantom limb syndrome, the patient feels like get the sensation that the amputated limb is still there.
Okay.
So
that's
to inhibit that impulse.
Yeah. Okay. Yeah.
To inhibit those small impulses, we can stimulate the touch receptors, so that with at the dorsal horn gate, these are the pain, the impulse that come from the phantom limb will be inhibited.
Okay. What is mirror therapy in phantom limb?
Where we keep the patients the normal limb in front of the mirror and demonstrate that the other limb is still there. And
okay, so kind of a desensitization, right? Now you talk about the phantom limb and phantom pain. Okay, it's difficult to manage. Anyway, what else are you going to advise this patient, particularly about something? I'm very interested in knowing about that. When the patient, we are trying to discharge this patient, you talk about the comorbidity assessment, so many things, but one particular thing, important thing. What's that?
The importance of physiotherapy, sir, to continue muscle.
Yes, that's also important. What's the other thing? We have actually forgotten.
Maintain hygiene of the stomach care.
Of course, you have to, but what else? The other thing, can you guess? What about the other side?
Yes, sir. Yes, we have to.
We have to what?
Advise to have the food care.
Okay. Food care, what? Food care? And?
To maintain the hygiene and look after the, check the food every day for any wounds or ulceration.
Yes. And specifically about footwear.
Yes.
Because this patient has already got deformed foot, and if you ask the patient to walk bare feet, and of course patient might develop ulcers. It's very difficult to manage, and this patient has very high chance of losing the other leg because his whole weight is going to be on the other side. Plus, there's a deformity, and this patient may have some occlusive artery disease also. If there's a minor injury, that can precipitate another sort of amputation. So this foot is at very high risk state. So you have to advise that. That's the most important thing. All right, Pinto, I think you can move to the other one.
I think it was very clear that the parts where she had to study, she was really good in presenting, but the parts where the observation was involved,
exactly,
or ward work or experience was involved, it was very annoying to listen, right?
Yes.
Both candidates, the examiner was talking more than the candidates. So I'm going to be really blunt, but both were not good, right?
Yeah.
But sir, this patient was there for the last 10 days or so in a female ward.
Exactly.
I see.
Right. The parts where the observation, what can you see? Those things you had to prompt like 100 times. Or when you ask what advice you will give, you just bat on with a list which was studied previously.
Exactly. Those who are in the books.
Yeah, that is not going to give you any marks because these advices are being printed on sheets, right? That doesn't require a doctor to give those. What your observational power was like, what deformity you can see, but then what is there in the metacarpal tailor joints and all that. Individually, she could answer hyperextension, flexion, and then work it out. So what is there? It is a claw. With the blind man describing the elephant, right? Observational powers are very less because you don't practice. I think the initial the problem is that you don't practice, right? It was very clear. Yeah. So I think the examiner is tired.
Then shall we move on, sir?
We'll move on. Pramod, would you take this, sir?
Yeah. So who's going to volunteer?
Sir, sir, I'm going to volunteer.
Okay. Can you describe what you can see?
Sir, actually, sorry, sir, I can't see the picture.
Can you see now?
Hirusha, you should be able to see that because it's there now.
Everybody can see it.
Okay, if we can't see, can someone else volunteer and do this, please?
So I can see now. Okay, so, it's like there is wasting of the lateral aspect of the thenar eminence in bilateral hands.
The lateral aspect of the thenar eminence, the medial aspect is all right.
So it's more in the lateral aspect, but it is wasted in both medial and lateral. And
any comparison between the two hands, or are they?
So it is more wasted on the right hand, and more wasted in the right hand. So.
Anything else that you want to tell me if sort of a patient comes for your exam? Anything, any negatives that are important, or? Okay, so what do you think has happened here? What is the problem?
the patient may be having a carpal tunnel syndrome, which causes the
Can't he be having a injury to the median nerve at the wrist?
yes, it's possible.
What sort of injuries can happen at the wrist?
At the wrist, at the level of the wrist, the median nerve damage due
What
to
sort of injuries?
wrist fractures affecting the carpal tunnel, affecting the compression of the median nerve.
So is it worthwhile telling me that there are no abnormalities at the wrist joint? Obvious.
Yes, sir.
What else can damage the median nerve at the wrist?
At the wrist level,
Can someone cut it with a knife or a sword or something?
yes, in self-inflicted injuries and things like that.
Is it worthwhile telling me there are no scars?
Yes, sir. Yes.
Yeah, none of those answers will give you any marks, right? Because I'm telling you the answer and you're saying yes. Right. So you think is a problem is with the median nerve, and why? Okay, so you say it's a carpal tunnel, and any simple way test that could differentiate whether it's carpal tunnel or it's a damage to the median nerve?
So I can tap on the carpal tunnel, tap on the wrist on the side of the median nerve, and the patient may feel tingling sensation if it is due to carpal.
That test is going to differentiate between an injury to the median nerve or whether it's carpal tunnel syndrome.
Yes.
No, right? How sensitive is that? What is that test that you mentioned?
Tinner's test.
How sensitive is it? 100% of the time when people have carpal tunnel, you will get that Tinner's test.
No, sir. About 60% sensitive.
What is the difference between an injury to the median nerve at the wrist versus a carpal tunnel syndrome? What is the major difference neurologically? What are the components in a nerve?
The sensory, motor, and the sensory and motor.
So which component will get affected if it is carpal tunnel?
If it is carpal tunnel syndrome, it can affect both sensory and the motor components.
Really? Or if it's what supplies the sensation over the theina eminence?
The sensation over the theina eminence is supplied by not from the branch going through the carpal tunnel. It passes above the flexor.
In carpal tunnel, you can get both sensory and motor affected.
In the theina eminence, it's only the motor is affected in carpal.
Just now you said in carpal tunnel, both sensory and motor aspects will be affected, right? Am I right?
Yes, sir. Sorry, sir. I was mentioning about the sensation over the fingers.
It's self-contradiction, right? That's the biggest mistake you can make at an exam, right? So the cutaneous branch travels above the carpal tunnel or the flexor retinaculum, right? So how are you going to test this?
By looking for the sensation over the palm, over the theina eminence, by looking for sensation. And
so how are you going to look for sensation? When you're looking for the sensation, what is the principle?
We ask the patient to close the eyes, and we using a cotton wool, we touch on the palmar area and ask the patient whether he can feel and compare it on both hands. and we can look for the ability of 2-point discrimination. And
now sensation, you are going to compare the both hands. But can you see this patient is having an abnormality in both hands now? How can you compare two abnormal areas? See, stick to the principles, right? You want to compare something with what?
With the normal.
So?
With other, with the rest of the hand, which is proximal to the carpal tunnel.
With the forearm.
Forearms.
Right? Because if at all you're suspecting something at the wrist, so you want to see whether the sensation is affected beyond the level of the wrist. You check an area proximal to the wrist with the thenar eminence on both hands, right? Okay, so what do you expect here? The sensation to be affected or not?
If it is carpal tunnel syndrome, the sensation is not affected.
Right. So how are you going to elicit the motor function?
You can ask the patient to abduct the thumb and check whether he can perform it even the resistance.
Okay. Can you describe what abduction is?
Abduction is asking the patient to elevate the thumb toward the ceiling upward.
Why? What are the muscles here supplied by the median?
Abductor pollicis brevis, opponens pollicis, and flexor pollicis brevis.
So why are you just checking abduction? Can't you check opponents?
So we can check all, but in abductor pollicis is solely supplied by the median nerve, and the other muscles have supply from the ulnar nerve as well, partly from the ulnar nerve.
Okay, so what are the other tests that you would do to confirm that this is carpal tunnel?
We can ask the patient to perform the Talon's test to flex the both wrist in a inverted prayers position, and
okay. What are any other predisposing conditions that give rise to carpal tunnel? If you all have to ask from the patient, what are you going to focus on?
Conditions which can increase the pressure inside the carpal tunnel, like the amyloid deposition in chronic kidney disease, and endocrine conditions like acromegaly, diabetes, hypothyroidism, or arthritis conditions like rheumatoid arthritis or osteoarthritis, or
if the examiner asks you, can you quickly assess whether the ulnar nerve is affected as well? You are going to do that.
We can
what are you going to observe in the hands to see whether the ulnar nerve is affected?
The cloving of the hand.
That depends on the
site. If the ulnar nerve is damaged in the wrist, there will be a.
What are the muscles that will be wasted? What is the characteristic feature in the hands?
Wasting of the hypothenar eminence, and
hypothenar eminence is not anyway very dominant. Do you look for the dorsum of the hand? What will you see in the dorsum of the hand?
The guttering in the dorsum of the hand.
Guttering. What is the test you will do if they ask you? So when why do they have dorsal guttering? What are the muscles that are affected?
The dorsal interossei muscles, and
so what do they do? What is the action? What is the test you do? Using a piece of paper?
we'll ask the patient to using their fingers to grab the piece of paper. It is abduction of the fingers. Sorry, the adduction of the fingers.
Right. What is the test that will do to confirm whether it's carpal tunnel syndrome or not?
The investigation, we can do nerve conduction studies, impaired conduction of impulses.
What do you test? What do you test in that?
The conduction of the electrical impulses through the median nerve beyond the carpal tunnel is impaired, sir.
How do you know it's impaired? Is there a normal value?
I'm not sure, sir.
You have to be sure. Huh? You compare it with the ulnar nerve of the same site.
Okay, sir.
Okay. Right. What is the treatment for carpal tunnel syndrome?
The definitive treatment is the surgery to relieve the pressure by doing the making incision in the flexor retinaculum, and until the surgery is done, we can use splinters and also steroid injections to the carpal tunnel.
How is a carpal tunnel? Have you seen a carpal tunnel release?
I have not seen, sir.
How is it done usually?
It is
special ways?
done under the local anesthesia, and it can be done endoscopically or as open surgery. Longitudinal incision is made in the.
Well, no, there's one more principle, important principle that you undertake during carpal tunnel release.
To minimize the damage to the other important structures.
You apply a tourniquet at the arm. Why? So that this is an important principle that you need to know, right? We usually apply a tourniquet to get a bloodless field, right? Because you can't do it when it's bleeding, and you know the palm is very highly vascularized, so you need to apply a tourniquet to prevent the blood flow. And then the discussion will go towards what sort of anesthesia you will use, and the pros and cons of using local anesthesia versus regional anesthesia versus general anesthesia. So that entire discussion cannot be taken forward unless you know that we put a tourniquet to achieve a bloodless field, right? Okay. So there is a huge deficiency of knowledge there. Okay, right. Pinto.
Yes, sir. We can move on to the next one, yes, sir. Hello.
If anyone wants to comment,
yeah. I think we'll move on to the next one, sir. Yeah. Who's going to present? Any volunteers?
Sir, I'm going to do that.
Right. Okay. Now I'll play a video You have a look, and then Pramod sir will ask you questions. Huh? I will play the video a few times if you want.
Okay, okay, sir.
I'm going to play it again. Okay.
Did you see anything abnormal, or was it?
Yes, sir. I saw there was a snap in the middle finger that moves quickly than the other fingers.
Tito, can you play it one more time? Right. So there was a snap.
Yes, sir.
Why do you think there is a snap?
Mm,
What's
so,
called that condition?
yes, that is called trigger finger, sir.
What is the pathophysiology? What happens there? What's the abnormality?
Yes, sir. There is a synovial sheath that covering the flexor digitorum superficialis and the flexor digitorum profundus. So when there is a nodule formation in the flexor digitorum superficialis or profundus, and the mechanism of action as a pulley is blocked, and so that tendon stuck in the synovial sheath, and
Sorry.
suddenly
Can you tell me where the problem is? Is it the tendon or?
nodule formation in the May tendon, but it traps in the synovial sheath.
No. The problem, the initial problem is in the synovial sheath. There's a thickening of the synovial sheath, right? Where the tendon enters, especially at the opening. And that's where because of the sheath is swelling, the nodule is a secondary thing. Nodule occurs later because there is pressure around the tendon. The primary problem is with the synovial sheath. Okay.
Yes, sir.
What are the conditions predisposing to this abnormality? Any other comorbidities?
That can be due to the trauma. Also, most of them are idiopathic, and in the children, they may be congenital.
No. In the idiopathic people, what other diseases are connected to this?
They can have diabetes mellitus.
An undue straining, right? If you're working too much with that tendon, the sheath gets inflamed and the sheath thickens, and then that causes the locking of the tendon. Okay, so and what is the other physical sign you will see here? I mean, these are short cases, so these basically these are just based on observation and one or two physical signs, and then about your background knowledge. So what is a physical sign you can elicit there?
So I want to check for the tender nodule that is present in the metacarpal, above the metacarpal head. And
yeah, so what are the treatment options available for this?
So first they can treat it with heat fermentation and with diclofenac sodium gel, and if it is not responding, can
gel for trigger finger.
With heat fermentation.
No, it is not going to do anything.
Then do a surgical intervention to release the synovial sheath.
But there is something non-surgical you can do.
Steroid injections.
So steroid where?
To the pain causing to the location that.
What anatomical structure?
To the synovial sheath.
To the sheath, right? It's not the tendon, but to the sheath. Okay, you first try with steroid injection, and then if that fails, you go for a release. Okay. Do you know any other condition where the tendon sheath of the tendon sheath connected to the thumb is affected? Any special disease? There is people can't they can't extend their thumb. It's very painful. There's tenderness at the wrist.
The Quervain disease.
What? Sorry?
So the Quervain disease.
The Quervain's disease. Yeah. It's sort of the same pathology. There is inflammation of the synovial sheath of the extensor pulsus longus. And that is also treated in the same manner. First you try with pain medication, steroids, and then you have to release the tendon. Right. Okay. Pito, I think that short case is a short
That concludes. Yes. Students, are there any questions? Okay, so then we can conclude for today, I think.
Yeah.
Okay, thank you very much.
Okay. Right.